Hammer identify one of you with a strabismus? Was one of you a guinea pig at all? Okay, then we'll figure it out.
I know I have a little bit of latent strabismus.
There we go. All right, you're on the hook, but not quite yet. So I want to start out with just making sure that we have the right names and all. And so when we test, we're going to start out with just thinking about eye movements. So if we just test the movements of one eye, what are those called?
Elevation.
But in general, if you test one eye moving, left, right, up, and down, those are called ductions. Okay. If we test both eyes moving up, down, right, left, what are those called? Versions. And what's the third? We have ductions, we have versions. What else do we do? Well, we don't really test torsion normally, although we'll talk about that. But what do we do when we look from far to near or near to far? Convergence or divergence. So those are vergence movements. So when we test eye movements, one aspect is to test ductions, another is to test versions, and another is to test vergence. We also make two types of eye movements. We make fast eye movements, and we make slow eye movements. Can anybody tell me why we need two types of eye movements, fast and slow? What's the use of a fast eye movement? Why do you suddenly make a fast eye movement? What are you looking for? I see something over there. Is that friend or foe? I want to see what that is. We are foveate animals. And we see perfectly, hopefully, when something is on our fovea. So we want something in our peripheral field to be on our fovea. And we use a fast eye movement for that. But what if that's moving? We want to keep it on the fovea. So we use a slow eye movement, at least up to a point. Does anybody know what fast eye movements are called? You're almost saccades or saccades. Some people say it's from the French word saccaire, meaning to turn the horse's head with the reins. Slow eye movements are called pursuit movements because they're pursuing a moving object. So when we test eye movements, we can start, I usually do, with range of movement, left, right, up and down. And I test this fast eye movement. Look at my finger, keeping your head steady. Look at my finger, look at my nose, look at my finger, look at my nose, and slow eye movements. And basically you go about, the pursuit system can go about 30 degrees a second. So 1,000, 2, 1,000, 3, 1,000. Most of our residents do. Like this, I don't know what they're testing when they do that. The other thing that's kind of interesting is that, I don't know if you've noticed it with your patients, but if you test eye movements way over to the right, way over to the left, sometimes, even though somebody's looking all the way over to one side, you can still see a little sclera showing way over there. And you say, and our residents will say, oh, there's some limitation of abduction. Usually it's bilateral. But think about this. If somebody moves all the way over to one side, and the abducting eye has a little limitation, and the adducting eye doesn't, if you measure alignment in that far gaze, what will you find? If one eye is going all the way over and the other eye, one eye is going all the way over, the other eye isn't, you'll see an ESO deviation because the one eye is truly restricted. So if you see a patient who doesn't have any major complaints, and they look way over to, you test them, they look way over to the right, and there's a little bit of sclera showing, lateral sclera showing, over to the left a little bit, and you say, oh my gosh, is this thyroid eye disease or something like that? You're going to test their alignment, and if they don't have an ESO deviation, it's just them. They're fine, that it's just the way their lids are shaped or something Okay, so with that preamble, what is atropia? If somebody has an esotropia or exotropia or hypertropia, what is the definition of atropia? Yes, it's a manifest strabismus. It is there all the time. What is aphoria? It's a strabismus that is only present when you artificially break up fusion. So atropia is manifest. It is there. You're going to see it when you do the test the right way. Aphoria is more difficult to find because it's only there if you break up fusion. Then there's something called an intermittent tropia, which, at least from my standpoint, is the patient who says, well, sometimes I see double. In those patients, it can be very difficult. If they're tired, you can break things up. Or sometimes they'll be straight, and we'll do the tests that we're going to do in a moment, and you don't see anything initially, and then after a while. So we're going to start out, at least in general, when you test uh, the alignment of the eyes, we're going to test first for atropia. That's the easiest thing to do. And I'm going to test this gentleman. We'll see what we can do. So as I said, atropia is a manifest strabismus. So if he's got one, we should see it when we cover one of the eyes, because one of the eyes is looking where it should be, the other eye's looking somewhere else. And his brain is so interested in, let's say, when he looks at that flower pot, his brain is so interested that instead of seeing two overlapping images, I mean, after all, the phobia is looking, one eye is looking here, the phobia, another eye is looking over there. Why doesn't he see two overlapping images? Because the brain is more interested in what you're trying to see than in what your phobias are seeing. And so the brain says, well, I see that here, but I also see it over there. That's the binocular diplopia. So if he has atropia, if I cover the eye that's fixing, the other eye will move to take up fixation. It wasn't looking at the place it should be, so it'll move to take up fixation. On the other hand, if I cover the eye that is not fixing, the fixing eye isn't going to move because it's already straight. So let's see if you can look directly there. So we do what's called a cover-uncover test. So I'm going to just look at his left eye. Okay. So this is a cover-uncover test, and basically it's pretty straight. But let's
Maybe
break
it's
up.
not much.
Not much. But that's
Sorry
okay.
to
That's
disappoint
no,
you.
no, no, not at all. No, no, you're doing just fine.
I just thought I had a little squint.
Actually, well, we'll show it, hopefully. So now I want to break up his fusion. So I do, instead of a cover-uncover, I'm going to do a cross-cover. And this is designed to break up
So it's
fusion.
the same point.
Yes, please. And he's just got a little bit of movement, little exodeviation, I think. Okay. And that's really the long and the short of it, at least from the standpoint of cover testing. You do a cover-uncover to see if there's a manifest strabismus, and you do a cross-cover to see if there is aphoria. However, there are sometimes when even that won't work. So one of the things you can do, and especially in the setting of an emergency room, is to use a red glass and a light. Now remember that everything is reversed. So if you have an exodeviation, what you see with one eye will be on the opposite side, like so crossed. If you have an ESO deviation, it'll be on the same side. Let's see if he does. Can you hold this, please, over your right eye? By convention, we always will put the red glass over the right eye. Excuse me. Okay. So here, turn toward me, please. Okay. So do you see one or two lights?
I see one.
Okay. And it's sort of reddish white?
Yes.
Okay. So he's a line that doesn't break up his fusion. Okay. And we can go over, follow, holding your head still, follow the light. Move your eyes. Still one?
Yes.
Okay. Now, if you'll give him that Maddox rod, those lines are designed, they're actually small prisms. And so if he's holding it, I can't tell which way. Do you have a vertical or?
Yeah, you want the lines to go like
Okay, so
horizontal?
So that will create a vertical red line. And so if he has a deviation, he'll see a red line and a white light. And he'll tell us where that is. So do you see the red line?
I see a red line.
And a light.
Yes.
And which direction is the line? Is it vertical or horizontal?
It's
up and down.
It's up and down.
Because he's holding the lines of the rod. Maddox rod is horizontal, so it does a vertical line. And is the vertical line to the left or right through?
To the left.
Exactly. So that's crossed, right? It's over the right eye, but it's on the left side of the light. So he has a little exo deviation, which is what we thought. Okay, now turn it 90 degrees.
So now it's
Okay, now you can see, now you have a horizontal line. And is the line above or below or through the
slightly
line?
above.
So he has a little hypotropia on that side. Everything's reversed. So if he sees the line above, it means the eye's a little low. If he sees the line below, the eye's a little above. So you see how easy it was to use that Maddox rod. So why don't you try it? Why doesn't she try it on you? And we'll see if, try it on you. You go over there, put it, and we'll see what she says. Keep your glasses on.
Okay.
Okay, look at my light. Okay, do you see a line and a light?
Yeah. The line is like this.
Okay.
The light is here.
Okay, so she has a small esotropia or esophoria. That is, the line is on the right
Yeah,
side
it's here.
and the light's there. So ESO uncrossed. Now turn the thing 90 degrees. Okay. You see a horizontal line. And where's the light? Right through it.
Just under.
Okay. So maybe just a little hyper there. This is so easy to use in the emergency room. In the clinic, you can do more, but I find that if somebody says that they have diplopia and you do a cover uncover or cross cover test and you can't tell anything, and yet the patient swears, cover one eye, it's gone, cover the other eye, it's gone, and yet you can't be sure on a cross cover test that you see it. Get either a red light and a line, a Maddox rod, a red Maddox rod, or something like that. The other thing that you can do, can you pick it up as well and just hold it so, well, we'll do it so the lines are horizontal. Okay? And what I didn't ask you was, you have a vertical line. Is it straight up and down? Okay, so there's no torsion, because you can use the Maddox rod for torsion as well. Now turn it 90 degrees, and we'll see if you've got a horizontal line.
Yeah.
Is it strictly horizontal, or is one side a little higher?
I think it's horizontal.
Good.
The nose is a little bit above the light was a little bit above the line.
Okay, good. So really, that's all there is to it. You can use, especially in the emergency setting, a Maddox rod or a red line in the light. And again, it depends in part on what the patient tells you so that you have an idea. We're going to talk tomorrow about these various optic neuropathies. And the fact of the matter is that when we wonder what the problem, what a neural problem is in a patient, I would say that 99% of the time, by the time we take a good history, we know what the problem is likely to be, and the examination is merely confirmatory. And that's the problem with neuro-ophthalmology for ophthalmologists, is we are so fortunate in ophthalmology that we can see virtually all the working parts of the eye. So patient comes in and you don't need to get a serum rhubarb test or whatever. You just look at the cornea and the conjunctiva and the lids and the anterior segment and the lens and the vitreous and the retina and this, blah, 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 and you're done. But with neuro, often there's an issue of the history and it may not be obvious. The eye can look perfectly normal and the patient has a brain tumor. So that's what scares ophthalmologists, because we can't see everything. And that's why you have to know the history. And you have to be able to do the examination. Patient comes in with a little binocular diplopia, and that could be the sign of a skull-base tumor or multiple sclerosis. Somebody comes in complaining of decreased vision, and there's a little bitty relative afferent defect, or maybe you miss the afferent defect, and the patient has a brain tumor. So as I said yesterday, this is, when we give neuro-ophthalmology talks, meetings, usually the hall is packed, not because people want to know about neuro-ophthalmology. They're scared that they're going to miss a patient and the patient will die. And so it's great to depend on fear when you're lecturing. Trying to think what else we could talk about. Any questions that you have in terms of testing eye movements?
So I was intrigued by this Maddox rod.
Yep.
You call it the Maddox rod, right?
Yes.
So would you say that is it as good as testing with the if you only were allowed to make the one test?
I test with a Maddox rod. I think it's better because it's more dissociative. And as we saw with you, I mean, when I did a cross-cover test on you, I just detected a tiny little exodeviation, but it was really minimal. But as soon as I asked you, you were very clear as to where the line was and where the light was. So I really like that. I think it's very dissociating to have both the color and the line. And now, one thing we didn't talk about, but I just remembered, is in the appropriate setting, like the patient who comes into your clinic and is complaining of double vision, you'd like to know not only that they prove to yourself that they have an exo or an ESO or a hyper or some combination, but also how much it is. And I know Dr. Carden told you about how to measure a relative afferent defect by putting increasing neutral density filters over it. I never do that stuff, but that's okay. As far as I'm concerned, an RAPD is an RAPD, and let's move on. But at Iowa, they do that. But you can measure the amount of a strabismus by using prisms. A prism moves the image of an object toward the apex. And the easiest way to think about how to use a prism is that if somebody has, let's say, an exotropia, you can imagine that the lateral rectus is tight, so it's pulling the eye over. So you want to cut that lateral rectus. So you put the prism apex in the direction of the deviation, in the direction of the tight muscle. It's not really a tight muscle, but if it were. So you're trying to cut the muscle that's pulling the eye over. So for an exodeviation, you use a base in prism. The base is in, the apex is out toward the exo tight lateral rectus. If it's an ESO deviation, you use a prism with the base out, so the apex is pointing in toward the nose. And you try, and you do a cover test, and you say, or you can put a Mannix rod over and say, okay, is the line closer or further apart? And you do that until you have neutralized however you're doing it. If you're doing a cross cover test, you have a prism, you hold it up, and you go back and forth. If you're using a Mannix rod and a light, you have the same thing until the light goes directly through the line. So you can use prism to measure. And in fact, the great thing is that if it's a benign process, if it's somebody like you who's always had a problem, but now you're getting older, you will, and your strabismus may break down, and all of a sudden you're seeing double, and it's hard to concentrate, hard to study, and whatever. You could be fit with a press-on prism, these little plastic prisms, put them on a glass, put them on. That's all there is to it. I guess since we have a little time, we haven't talked about torsion at all. And one of the things I think is really neat is fourth nerve palsies and the issue of, about the Wilczewski three-step test for a fourth nerve palsy. You have a hypertrophic eye. And so you determine which eye is hypertrophic. Let's say I'm the patient, I have a left fourth, so I have a left hyper. It should get worse in the field of action, the vertical field of action of the left superior oblique. So when I go have the patient look, or when I look over to the right, it's worse. When I look to the left, it's better. So that's the second step. And then when I tilt my head to the right shoulder, things are better. But when I tilt my head to the left shoulder, the side of the hypertrophic eye, everything is much worse. Do you have any idea why that is? It's really kind of cool. Basically, the brain hates torsion. When you tilt your head over, your left eye extorts, your right eye intorts. The brain doesn't like that. So it tries to intort the left eye, extort the right eye. When I tilt my head to the right, the brain wants to intort the right eye, extort to the left eye. The superior oblique is an intorter, but it's not working. So when I tilt my head to the left, the only other intorter is which muscle? The superior oblique intorts. What's the other intorter? The superior rectus. So it's going to try to intort, but what does it do? Pulls the eye up. The superior rectus, superior oblique intort, the inferior rectus, inferior oblique extort. So that's the basis of this so-called three-step test, the Wilczewski head tilt test, is you have a hyper, which could be due to weak reduction of the eye, or of one eye, or weak elevation of the other eye. And by moving the eye in certain directions, depending on, I can't give you a whole lecture on a fourth nerve palsy, but you can determine which muscle is affected. But the key to the Wilczewski test is basically, and sometimes you don't even need the second step, left, right. You just say, okay, patient has a left hyper, tilt the head to the left. The superior, if it's a superior oblique palsy, the superior oblique's not working, the superior rectus is, it'll pull the eye up. It's much worse, that's a fourth, and you move on from there as to what the possible cause is. Dr. Carter.
It's time to see the effect of coffee on the visual field.
It'll broaden mind. Anyway, that's sort of the situation. I'm trying to think if there's anything more. Any questions that anybody has in terms of measuring eye movements or things that confuse you in the clinic?
With cover and non-cover tests, would you do it near or far at different?
It's a good question. In general, you'd want to do it with the patient looking at a distance. The problem with looking at near is that convergence can dampen a strabismus. Unless the patient says, of course, when I try to read, I have horizontal double vision, and then that suggests there's a convergence insufficiency. under those circumstances, you want to test convergence. And the only thing I'll say about that is when you're testing convergence, always use an accommodative target. You'll see people use a pen or a hand light or something like that. That may not be a strong enough stimulus for convergence. So we have, I don't see anything over here, but I think I do. Well, I guess. So this might work. It's got some writing on it. So it says Visco Fresh. So if the patient can see it, you could say, look at the O on this target. We have little Snellen charts on our on some of our includers. But you want to make sure that you have a good enough accommodative target to make the patient really look closely, and then you bring it to and fro. You can measure accommodation. Do you know about the rule of fours, by the way? So if you ever want to figure out how much accommodation a patient should have, it's 4 square minus the age over 4. So 16 minus the age over 4. So at, let's say 60, the age 60 divided by 4 is 15. So 16 minus 15 is 1. So you have 1 diopter of accommodation at age 60. At age 16, 16 minus the age over 4. 16 over 4 is 4. 4 from 16 is 12. You have 12 diopters of accommodation. It's a really nice little formula to remember. Again, any issues? Okay. I think that's it. If you think of anything, I'll be around. And obviously, I'll be around tomorrow. So we'll talk then. Thanks.
Thank you very much.
I still am trying to figure out what those little orange things are.
Something with field of vision.
Oh, okay.
I don't know.
Did in terms of field of vision, did they talk to you about confrontation fields?
I think that's what Randy was talking about.
Okay. Very good. We'll let him do that. Good.
Thank you.
All right, thanks.